Hi, everyone. Mary Funseth here from Superior Health Quality Alliance. I'm a quality advisor with Superior Health and Metastar in the event that you've not met me before. We're entering into our third session for championing the cause for chronic kidney disease. And we're really so glad to have you here. We do record this so you can go back and listen again. We also have it recorded so that you can share it with your colleagues, or if for some reason you need to miss a session. This week, we're giving Dr. Campbell a short break, and we're bringing in Dr. Siegel, who you'll meet in just a moment. And I see a few more folks are just coming into the room, so we'll let them get caught up. And I will share my screen. Okay, is everyone seeing that all right? All right, great. Well, let's get started right away. And the first thing I want you to do, as always, and I know we've done this before, but just again, sharing your name, your title, what is your clinic or organization, where that location is. You can either say the city, state, or just the state. And, if you have any new ahas from what you've learned so far from session 2 or session 1, please chat those in as well. We really love hearing that. And before we go to our poll question, first I'd like to have Candy Coles reintroduce herself and give us just a little description of the organization that she is representing. Oh, Candy, you are on mute.
There we go. Yeah. So I want to say hi, everyone, and thank you for joining the webinar today with the presentation. I am the Quality Improvement Director with the Midwest Kidney Network. The Midwest Kidney Network is a nonprofit independent agency that has served patients with end-stage renal disease since 1977. Our mission is to assess and improve health care for people with kidney disease, and our functions include quality improvement, patient services, and maintaining the ESRD registry. For those that are unfamiliar with us, we do cover about 350,000 miles over Michigan, Minnesota, North Dakota, and South Dakota, including Wisconsin. And we collaborate with 525 dialysis facilities, 19 transplant centers, and 4 organ procurement organizations. And Dr. Siegel happens to also be our medical review committee chair. So welcome, Dr. Siegel, today. And Mary, did you want him to introduce himself right away?
Yeah, go ahead and introduce yourself, Dr. Siegel.
Sure. Hi there, everyone. My name is John Siegel. I'm a nephrologist at the University of Michigan, where I've been practicing for a little over 20 years now. As Candy mentioned, I help serve on the Midwest Kidney Network and their medical review committee and board of directors. In my clinical practice, I actually focus primarily on people with chronic kidney disease, and in particular, advanced chronic kidney disease. And so part of today's talk is going to be sort of the preamble and leading up to a little bit more about what I deal with on a day-to-day basis. I also spend quite a bit of my clinical practice taking care of patients with kidney failure who are either on dialysis, both in-center dialysis as well as home dialysis, as well as kidney transplant. So that's the bulk of my clinical work focuses in that domain. They do some work in our School of Public Health developing quality measures for dialysis programs at the national level, but we'll save that talk for another day. But in any case, I'm thrilled to be here and share a little bit about my insight about chronic kidney disease that people are likely to encounter and manage in a primary care practice, and some tips and tricks that hopefully I can pass along as we go.
We really appreciate you being here today. Thank you so much for coming. I'm going to launch our first poll. And basically, we just kind of want to get an understanding about, especially for Dr. Siegel, our speaker today, what is your knowledge about CKD medication? And as you can see here, we're asking you whether or not you have a basic or advanced knowledge, or you do not have any knowledge about it. Also, our second question today is, I am unsure of the best lifestyle changes to slow progression of CKD, and those, we're going to be talking about that as well. It's a true or false answer. So if you'll go ahead and take part in this poll, 2 poll questions, please, and then we'll move on. Oops. Okay, we're just going to give the poll questions just another couple of seconds here. Doing well to answer them today. Thank you. So we're going to end that poll and we're going to share the results. So it sounds like we have a great audience today to learn about what we're planning to share with you. So thanks again for sharing what you think in those poll questions. And now we're going to move on and we're going to turn it over to Dr. Siegel.
Great. Thanks. So I wanted to start out and talk a little bit about when we think about chronic kidney disease and risk factors for progression. I mean, that really, I think, is the important issue, because there are going to be a lot of people who are identified as having chronic kidney disease who are actually not going to progress to more advanced kidney disease or needing dialysis. And so it's helpful to be able to try and understand the whole risk profile. If we can actually just go back a slide. And was that the first one, or is there? Okay. So thinking about risk factors for progression, there are clearly risk factors that are beyond our control. So these are going to have to do with the patient's family history, their genetic makeup, things like that. Interestingly, I'm not sure how much people are up on the where we're at with this APOL1 gene, but we've known for a long time that Black individuals with chronic kidney disease tend to progress faster towards kidney failure than other groups, and what we've identified are this APOL1 gene variant, where if you have 2 high-risk alleles, so 2 copies of this APOL1 gene, that unfortunately is an indicator for more rapid progression. And so it starts to broaden our understanding a little bit about why some people tend to, with similarly or presumably, similar other risk factors, why some people tend to have more rapid progression than others. So understanding these kinds of things, I think, is important as we begin to do a better job risk stratifying people. Clearly, diabetes and high blood pressure are most common causes for kidney disease. So, and understanding the severity of those as they impact kidney disease is also important. We're becoming much more cognizant of acute kidney injury and its impact on progression of chronic kidney disease, as well as starting to try and come to terms with the obesity epidemic and the impact there on progression. Other issues, things like smoking, we know is an accelerator for chronic kidney disease, and obviously it's there's a whole group of challenges in terms of trying to help people in their efforts for smoking cessation, but framing smoking cessation as supporting their kidney health is another potential spin that we can put on those efforts. And then thinking about over-the-counter medications, non-steroidal use is obviously the biggest one in terms of putting people at higher risk. And we'll talk a little bit about nutrition and things like diets that are higher in protein tend to be less kidney friendly, And particularly of the type of protein, animal-based proteins tend to probably be a bit worse than plant-based proteins. So as we think about interventions to try and slow down disease progression, there's a lot of relatively low-hanging fruit that we can turn to try and help people outside of medications, which we'll get to as well. So if we go to the next slide. And so I saw this graph, which kind of I thought was a nice job of sort of highlighting at least two potential pathways. I actually think there's a third pathway that's not on here as well, which is sort of in addition to kind of a baseline rate of kidney function loss, there might be a line on that graph that's above that, which might be with the addition of some of the interventions we're going to talk about today. So clearly, people have some natural rate of progression, and sometimes when people lose kidney function, it really is in a linear fashion, and you can plot out the change in their glomerular filtration rate or GFR over time. And for some people, it's it truly is a straight line. But for many people, we see kind of the course at the bottom part of the graph where they'll have a series of insults, and no one single event may be enough to completely derail the train. But when you start to add up the sum of all these events, it's easy then to see how some people might lose kidney function quite a bit faster. So, they've thrown a few examples here, a non-steroidal treatment for gout, contrast for heart catheterization, maybe using an aminoglycoside to treat an infection, and then, potentially aggressive diuresis, and low blood pressure and an episode of acute kidney injury. And all those things over time might come together to have worsening kidney function than if none of those things had occurred. And similarly, outside of that baseline rate of kidney function loss, treating people with proteinuric kidney disease with, ACE inhibitor, angiotensin receptor blocker, or SGLT2 inhibitor, or Finerenone, those things might actually slow down that progression to buy even more time before people would potentially reach worsening kidney function. So if we go to the next slide. So, really the cornerstone for slowing down disease progression is control of high blood pressure. And obviously that's not news, but there are a couple things I'll highlight. One, which is that, there's not consensus on exactly what blood pressure target we should be aiming for. So I think that's the first thing to highlight. While it's clear, there shouldn't be anybody who's got a blood pressure above 140/90. So that's at least the absolute upper bar. There's been some controversy about whether lower targets like a systolic pressure of less than 125 or 130 would be appropriate. And a lot of that probably hinges on whether someone is spilling protein in their urine in the course of their kidney disease. So people with proteinuric kidney disease probably need to have a much more aggressive blood pressure target than potentially somebody with non-proteinuric kidney disease. And so that's kind of highlighted in this table that we know, for example, that a lower blood pressure target in people with proteinuria can clearly slow down progression to kidney failure and clearly improve mortality. And that's been shown in a number of different studies. And that's anywhere from 10 to 15% reduction in those outcomes. In patients with chronic kidney disease who don't have proteinuria, while aggressive blood pressure control can still be beneficial in terms of longevity, it's not at all clear that that has an impact on slowing down progression to kidney failure. And so that may be that difference in benefit is shown in the graph on the right, where we look at protein excretion that's along the x-axis there. And at the far right, you can see in patients who are spilling over 3 grams of protein a day, more aggressive blood pressure control has a much more significant difference in slowing down progression of kidney disease in the reduction in GFR, compared to at the left side, people that have less than a gram of protein, where there's clearly not much difference between usual blood pressure control and more aggressive blood pressure control. So I think the take home is, in people that are spilling protein in the urine, you have to be much more aggressive in their blood pressure control than people with chronic kidney disease who don't spill protein in the urine. Or just a reminder, because we don't do a very good job in many of our clinics with checking blood pressure, someone really needs to be sitting, resting for 5 minutes quietly. And ideally, we get an average of 3 readings when we're doing an office blood pressure check. Oftentimes, we rush people back from the waiting room to the exam room. We slap a blood pressure monitor on and check a reading. And that's probably not the best way to do it. Particularly if they've had trouble finding parking and ran in, in the first place. So I do put a lot of stock in home blood pressure readings and really encourage individuals with chronic kidney disease and hypertension to invest in home blood pressure monitoring. As you probably know, a good quality home blood pressure monitor these days you can get for $35, either at the drugstore or on Amazon. So blood pressure monitors are usually within most people's wherewithal. So if we go to the next slide. So beyond control of blood pressure and exactly how low to go is obviously how we get there. And the key thing to point out with the use of angiotensin converting enzyme inhibitors or angiotensin receptor blockers, ACEs or ARBs, is that really their benefit is in slowing down the progression of people with proteinuric chronic kidney disease. And I think people often lose sight of that, is that in individuals who do not have significant proteinuria, it's not that they would be a bad choice to use an ACE or ARB, but there isn't the same benefit is in people that have proteinuric kidney disease. So in someone who doesn't spill protein in the urine, you might look at it as, while it's certainly a good choice, you have probably a few more options in your toolbox to control blood pressure, and if for some reason they don't tolerate an ACE or ARB, I probably wouldn't lose as much sleep over it at night. And then some guidelines, because obviously in the primary care setting is when many people are in fact getting started on ACE or ARB. So we generally use about a 30% change in the creatinine from when you start the medication as a potential trigger to think about stopping it or doing some additional investigation as to why there's such a big bump up in the creatinine. So I do think it's important to get blood work anywhere from 1 to 2 weeks after starting an ACE or ARB, in part to make sure that the creatinine remains relatively stable, in part to make sure that they tolerate from a potassium standpoint. Most people are not going to have a huge bump up in potassium and are going to tolerate it. And you really have to ask yourself, for someone with proteinuric kidney disease, where there's clear-cut benefit in an ACE or ARB, how comfortable, how high of a potassium are you comfortable with before you would consider stopping the medication? And so given the benefit that's at stake here, I would argue that most people can do just fine with the potassium in the low to mid 5s. And so in that setting, I would, in my practice, I do not stop an ACE or ARB if their potassium is less than 5.5 and they're, achieving good blood pressure control and hopefully some reduction in their proteinuria. And then you can think about if somebody does have high potassium with an ACE or ARB, is there an opportunity for nutrition counseling and helping them follow a lower potassium diet? And in potentially a more extreme scenario, would you even consider using a potassium binding resin medication to lower their potassium so that they could still enjoy the benefit of an ACE or ARB and be able to tolerate from the potassium standpoint? So I generally don't like to treat the side effect of one medication with another medication, which essentially is what that would be doing. But because the benefits are so large here, it's at least worth considering based on the degree of kidney disease, the degree of proteinuria, and the potential benefit from being on an ACE or ARB. Just a reminder, ACE inhibitors, there's that nuisance non-productive cough that we see in about 15 to 20% of patients. Generally switching people to an angiotensin receptor blocker is a good way around that. And in this day and age where they're both generic, you could make a pretty good argument to just start with an ARB and not have to worry about a potential cough seen with an ACE inhibitor. Angioedema, although it's kind of a feared complication, fortunately is quite rare. And obviously you need to be mindful of people women of childbearing age who may want to become pregnant, where you would not want to use ACE or ARB for therapy there. So let's go on to the next slide. And so for a long time, ACE and ARB was really our mainstay of treatment for chronic kidney disease, and we didn't have a lot else in our armamentarium that would actually slow down disease progression. And so that's really the key with ACE and ARB, is slowing down disease progression beyond what would be expected for just lowering blood pressure alone. So there's that kind of synergistic effect. And for the last several years, we've had SGLT2 inhibitors, and those have been shown in both diabetic chronic kidney disease as well as non-diabetic kidney disease, also to most importantly slow down the decline in kidney function, delay time where dialysis is needed, and even improve mortality. So these have been real game changers for those with chronic kidney disease to now have a second choice to slow down disease progression beyond therapy with ACE or ARB. So for non-diabetic kidney disease, the only FDA-approved drug in that setting is dapagliflozin. For diabetic kidney disease, you've got a couple other choices on the board to use. Many people in diabetic kidney disease, and pagliflozin would be probably I would think would be one of the more popular choices amongst the three there. But probably there's a class effect, so it shouldn't really matter a whole lot between them. Just as a warning, so the FDA package insert says that you should not start an SGLT2 inhibitor if the GFR is less than 30 milliliters per minute. We'll tell you there's been a number of studies that have looked at patients with chronic kidney disease in the 25 to 30 range for their GFR. And in that setting have found that starting an SGLT2 inhibitor seems to be equally safe and have a similar benefit to folks that have a GFR that's greater than 30. So in my practice, I am starting SGLT2 inhibitors as long as the GFR is above 25. You just want to be mindful that the package insert says 30 and that there's a little bit of a gray zone there in the 25 to 30, but as best we can tell so far, seems to still be reasonable in terms of the number of people that you can reach. And then interestingly, there's no stopping point. There's no guidance in terms of stopping an SGLT2 inhibitor. So even if the GFR goes down lower, you can still keep people on therapy, at least up until the point where they would be starting dialysis or kidney transplant. You do need to be mindful. The biggest issue probably with SGLT2 inhibitors is you're having people spill glucose into the urine. So they're going to have a mild diuretic effect, which may be helpful in controlling blood pressure. But if they're on a diuretic already, you may be able to stop the diuretic depending on the potency and what they're taking, and use your SGLT2 inhibitor for a diuretic-like effect. You just need to be careful because we're putting glucose in the urine. There is a potential risk for urinary tract and genital infections. And so is one of the side effects to be mindful of. And if we go to the next slide. So we've talked about the benefit of ACE or ARB. We've talked about the benefit of SGLT2 inhibitor. What happens when you take both of them and put them together in terms of the combined benefit? And this was a recent study that took data from 3 trials that had already been published and basically looked at what are the potential benefits of combination therapy using both versus no therapy. And so their composite, the outcome that they looked at was either a doubling of the creatinine or progression to kidney failure or patient mortality. And impressively, when people are on both forms of therapy, they found a 65% reduction in the relative risk of one of those composite endpoints. So put another way, if you look at someone who is between the ages of 50 and 75 years of age, and you put them on both forms of therapy, both either ACE-ARB and an SGLT2 inhibitor together, you can get, based on the study data, you could get 17 years as opposed to 9.5 years with no therapy before you reach one of the composite endpoints. So about a 7.5-year gain in survival. Now, if you account for how people do in the real world, which means I don't always take my medication every day, or I don't follow things quite as potentially rigorously as I might in a clinical trial, the gain is probably a bit less, but still somewhere in the 5.5-year ballpark, which is really impressive to be able to, to either help extend somebody's life or extend their life off of dialysis for that period of time is a real meaningful difference, I think. So we're not talking about pocket change here. This is, I think, has a huge impact on people's overall quality of life and their longevity when these two drugs are used together. So that wanted to share that finding with you. If we go to the next slide. And then the last drug that I wanted to mention, which is probably the newest of the three classes, is the non-steroidal selective mineralocorticoid receptor antagonist called Finerenone. This has been specifically studied in diabetic kidney disease. So unfortunately, people who have proteinuric kidney disease that's not due to diabetes are not eligible to take this medication. But given that diabetes does make up a significant proportion of our CKD burden, there are a lot of patients who can potentially benefit from this medication. And for a long time, we've used spironolactone as a mineralocorticoid receptor antagonist. And then eplerenone came out, and now Finerenone is the latest in that sort of progression. And for folks with diabetic kidney disease who are already on an ACE or ARB, again, studies have shown a significant reduction in progression of their kidney disease to kidney failure, improvement in mortality, and improvement in cardiovascular endpoints. And so there is a small increase in the risk of potassium, and particularly when you're combining it with ACE or ARB. But usually that hyperkalemia can be managed through nutrition. And so this would be what I would call, so having somebody on an ACE-ARB, SGLT2 inhibitor, and Finerenone would be what I would call triple therapy, and certainly optimal therapy in terms of slowing down disease progression, all other things being equal. And so if we go to the next slide. So the other thing that's really important and kind of a frame shift from the way we're thinking about managing comorbidities is the way we think about using statins in chronic kidney disease. So for a long, long time, we had essentially an algorithm where we would measure a fasting lipid panel. And if your cholesterol was elevated, most people would have a statin recommended. If your cholesterol panel looked okay, you got a pass from the medication. And it's become clear that, that having chronic kidney disease is an important risk factor for cardiovascular disease. And that most importantly, the use of statins for people with moderate CKD, essentially GFR less than 60, can significantly reduce cardiovascular outcomes, adverse outcomes like MI and stroke. And here's the key part, regardless of what their cholesterol panel is. So the general recommendation, you don't see too many recommendations like this these days, is that if you're over the age of 50 and you've got a GFR under 60, so I can remember those two numbers, over age of 50, GFR under 60, you should be on a statin. That the risk reduction in cardiovascular events is significant enough that if you meet those two simple criteria, regardless of what your cholesterol panel is, you should be on a statin. So we use the cholesterol panel to help guide the dose of the statin. So if your cholesterol panel looks pretty good, but you meet those criteria, low-dose statin therapy should be adequate. If you actually have dyslipidemia on top of it, then you moderate or other risk factors, potentially high-dose statin therapy may be appropriate. But the point is, get people on a statin if they've got CKD. or if for some other reason their 10-year risk is above 7.5%. So that's my plug for statins. We'll go on to the next slide. And then here I'll share some disappointing news. There had been a lot of interest in urate-lowering therapy. We know from observational studies that elevated uric acid is associated with more rapid disease progression, more rapid kidney disease progression, and that chronic kidney disease and hyperuricemia are kind of a two-way street. And so there have been a number of studies, however, that have looked at putting people on urate-lowering therapy, primarily with allopurinol, but even some of the newer drugs, and have unfortunately failed to find a significant reduction in major adverse cardiovascular events, failed to find a reduction in progression to kidney failure. And so at this point, at least for uric acid levels that are elevated, but still less than about 9, which was the cutoff that many studies used, it doesn't appear, and this is all assuming that people don't have gout or other indications for urate-lowering therapy. So they just have an elevated uric acid level, no gout, and their uric acid is less than 9. There's probably not much benefit in trying to get them on urate-lowering therapy, at least for cardiovascular or kidney outcomes. What's not clear to me is when we come across people that have uric acid level of 12 or 13, very, very high uric acid levels, those people may be in a different category, and I might consider putting them on urate-lowering therapy, even though there's not a lot of clinical data to suggest that it's going to have a major input. But at uric acid levels that are that high, they may warrant some special attention. So that thought is just in terms of uric acid. And if we go to the next slide. The other thing that I want to alert people to is the increased frequency of sleep disordered breathing or obstructive sleep apnea in the setting of chronic kidney disease. And one of the things that I've learned over the years that's been interesting is that often when we think of obstructive sleep apnea in the general population, we tend to think of middle-aged men, particularly of a particular body habitus, often with a large neck, is kind of fitting the sort of prototype for patient body habitus. And in the setting of kidney disease, all of that body habitus stuff goes out the window. And so you can have very slender, otherwise physically fit people that can have severe sleep apnea. So they don't fit the body type image that we often have. And it can have a significant impact on both control of high blood pressure and progression of their kidney disease. And so the first thing to recognize in the setting of CKD, sleep apnea is significantly more common than in the general population. It may be a mix of both obstructive and central sleep apnea. We know that having episodes of hypoxemia at night can potentially lead to tubular interstitial disease from a kidney standpoint, endothelial dysfunction, which can lead to cardiovascular disease, and most importantly, an accelerated reduction in GFR. And you can see that in the graph on the right, where there's really essentially a fourfold difference in decline in GFR between not having sleep apnea and having moderate or severe sleep apnea. So the take home here is have a very low threshold to send people for a sleep study, because I think it's relatively, at least I won't say it's easy to treat, but there's at least a clear-cut treatment plan for people that have sleep disordered breathing. So try not to miss that opportunity as it relates to their kidney function. And if we go to the next slide. Just a quick plug for vaccinations. And the reason why I bring this up is that if we wait to vaccinate people until they reach kidney failure and are on dialysis, vaccines don't work as well, and particularly with hepatitis B. So this is a plug that for people with moderate chronic kidney disease, being aggressive in offering hepatitis B vaccine earlier rather than later means that they have a much higher chance of responding to the vaccine than if we wait until somebody starts dialysis, where we really try and encourage vaccination for hepatitis B. And then obviously keeping up to date with flu, pneumococcal, and COVID vaccine. So if we go to the next slide. Just a quick word about some kind of high-risk medications to be mindful of. So I think everybody obviously knows about nonsteroidals, and I'll be honest that the people I worry about with nonsteroidal use are the people who are using nonsteroidals, you know, multiple times a day, day after day, week after week, month after month, year after year. So it's really the chronic long-term nonsteroidal uses that I worry about from a kidney standpoint. So even in my patients that have significantly advanced chronic kidney disease, taking a couple doses of ibuprofen once in a while is not going to cause irreparable harm to their kidney function. And there are obviously some conditions where nonsteroidals tend to work better than other forms of analgesia. So we want to get away from chronic use, but the occasional use, even for someone with chronic kidney disease, probably going to be okay. Herbal supplements, I just want to point out that there have been a number of studies that have looked at herbal supplements. These are typically combination herbal products, so multiple herbs mixed together that get marketed for different various ailments. Many of these herbal supplements have been shown to be contaminated with heavy metals, so things like lead, arsenic, and mercury. Those are all bad for your kidney function, amongst other things. So I do caution patients against taking combination herbal supplements as they're looking to do other things to support their kidney health. If someone is going to take a supplement product, I encourage them to look for the USP verified symbol on the bottle. That means companies have submitted to voluntary testing and might be some assurance that those products are freer from contaminant. You do need to be careful with phosphorus-containing bowel preparation. So really, it's mostly Fleet's phosphosoda enemas that we're talking about. That can have significant impact on kidney function, so I would avoid those. There's a lot of discussion about chronic use of proton pump inhibitors. So they're over the counter, they're ubiquitous at this point. And I guess the one thing I would say from a proton pump inhibitor standpoint is there are many people that have a legit indication. They've had bleeding gastric ulcers or other things where they really need to be on a proton pump inhibitor. What I do find are people that got started on PPI for more milder symptoms, some reflux, and then nobody's ever challenged them to see if they still need it long term. Nobody's ever tried to see whether they couldn't do just as well with an H2 blocker. So in those patients, I think it's worthwhile thinking about long-term use of proton pump inhibitors. But again, I don't lose too much sleep over people who have, legitimate indication they really need to be on those drugs. I think the risk in chronic kidney disease is pretty mild based on the literature that's been out there. Opioids, just as a point to mention clearance, there's delayed clearance of breakdown products from opioids, so you just need to be careful about dosing those. And then just to think about antibiotic dosing, gabapentin, those are ones that need significant adjustments. The direct oral anticoagulants, again, potential dose adjusted, as well as oral hypoglycemic. So just things to be mindful of in routine day-to-day prescribing. And if we go to the next slide, I'll just briefly say with imaging that at reduced GFR, MRI is going to be the safer way to go. Many people in the outpatient setting can get a CT scan with contrast, particularly if the GFR is above 30. I don't worry too much about it for venous administration, and trying to make sure that someone's volume status is that they're well hydrated beforehand can go a long ways towards mitigating risk. And so if we go to the next slide. And then I think this is my last one, just in terms of monitoring. So keeping a close eye on the blood pressure, I think, is critically important. Monitoring GFR so that you understand the timing of referral, so that you make help with a earlier rather than later transition from primary care into nephrology, I think is important. And it's important while you're monitoring someone with mild to moderate chronic kidney disease to make sure that that discussion makes its way into the clinic visit. I know that primary care docs are trying to manage multiple issues, and often this is lower down on the priority list. But the one thing you do want to avoid is at the point where you do put a referral in to see a nephrologist, let's say their GFR is in the low 30s and you're thinking maybe it's time to get nephrology on board. We don't want to be in the situation where when I see someone in clinic, I'm like, yeah, I look back, you've been living with chronic kidney disease for, 5 or 10 years. It's been a long time and it hasn't made it onto the radar screen. And so patients are quite surprised that their primary care doc has actually been checking their creatinine and GFR on a pretty regular basis, but somehow it didn't manage to make it into the conversation. So that's the one thing I just like to caution people about is even if you're not doing anything different, just make sure that it's on their radar. I think checking for urine protein is helpful to monitor the lipids we've mentioned, and then other downstream metabolic consequences like anemia and hyperphosphatemia are also worthwhile just keeping tabs on as well. So let me stop here. Thanks for your attention as we walked through all this, and happy to take questions or open things up for more discussion.
Thanks, Dr. Siegel. This is a lot of information today. So if anyone has any particular slide or part of the presentation you want us to go back to, that can be also one of your questions. I appreciate, Dr. Siegel, you bringing up the fact that sometimes primary care, because of all the things that they need to monitor, sometimes specific areas may be not necessarily missed, but as you put it, not brought up into the conversation. So I do challenge you all to sort of reflect on that and think about ways that you could look into your processes and think about how to improve that area. So let's open it up for questions. You may verbally, ask the question, open your mic, or if you would like, you can chat those questions in.
Hi, this is Claire with Midwest Kidney Network. And again, just what you were saying, Mary, with, primary care might be doing the monitoring, but even using, just that increased verbiage of, we're monitoring these labs and making these changes because we're monitoring your kidneys. There's a wealth of qualitative studies out there where they've interviewed patients and they say, I didn't even know I had kidney disease until I was on kidney failure, and even though the work was being done, they weren't aware of it. So I think that was just an interesting point at the end. But I did have a specific question for you, Dr. Siegel, with statin therapy. I had noticed, when I was working in the clinic still anecdotally, that it's really gotten a bad rap with patients. And in addition to talking about the risk of cardiac disease in this setting of kidney failure, is there one statin better than another, or one that's better tolerated when it comes to myalgias or in talking with patients, or switching therapies, just because it seems like patients seem to be more hesitant to be on statin therapies recently?
Yeah, you bring up a great point. So there are a number of drug interactions between statins and other medications. And so while on the surface, there's not one statin that is any better than others in terms of from an outcome standpoint, depending on patients' other medications, sometimes we prefer one over another to try and minimize the drug-drug interaction. So I'm very fortunate. I work with a pharmacist, and so I will often get input. You might consider this statin as opposed to that one based on the fact that they're taking this, that, or the other drug. So that's one thing to potentially think about. And your point about myalgias and muscle aches and pains are super common, right? And so there's a tendency to want to blame those medications for any ache or pain that comes up while they're on it. The actual frequency of having significant myositis and myalgias from statins is actually quite low. And so for most people, what I encourage is if they feel like they've had an adverse reaction with muscle aches and pains, I'll give them a break from the statin, try and, reset, hope that they are, doing better. And then that's a good opportunity to try switching to a different statin and see if it isn't tolerated better. And then particularly making sure that we're at a very low dose. So often I'll usually give that 2 or 3 tries. And then if on the 3rd try, we're just not making any progress, then sometimes I'll say, okay, maybe we've done as much as we can do here. But I definitely will ask people to do it at least a 2nd time, potentially with a different medication. And for some people, if there's really a large benefit, maybe even a 3rd time.
I feel like I need to create a poll question for next session. How many people heard that 60 if you're 50 and decide to go out, either look at their own EGFR or plan to look at their families? It was really a good way for us to think about that. Thank you. Thanks for your question, Claire. Annette has a question. What contaminants were in herbal supplements?
Yeah, so it's a really fascinating story. So there used to be something, and this probably wasn't appropriately named, but back in the day, there was something called Chinese herb nephropathy. And this was serious kidney disease that was found in association with people who were using certain Chinese herbal supplements, and these were often a combination. It turned out those products were contaminated with aristolochic acid, which is essentially comes from a plant that in some parts of the world contaminated wheat fields. So there was something called Balkan area nephropathy. So this was in the Balkans in Europe, and that was from the aristolochic plant that was contaminating the wheat fields, and it was getting ground up into the flour, and people were eating it in their bread. And was causing kidney failure. And this is the same thing that was showing up in the herbal supplements. So that's how it got on the radar screen initially. But more recently, when people have done testing, it's been the heavy metals. So they found significant quantities of lead, mercury, and arsenic that have contaminated those products. And so the hard part is that even if you buy a product that says made in the USA, and you think like, okay, I should be in good shape here, even though it may be the final, product assembly may be in the USA, often the raw source ingredients, the herbs themselves or the roots of the herb plants many of them come from Asia, where there is contamination of these heavy metals in the soil that the herbs are grown in. So that's how it gets there, and then gets into these products. And if it's not a USP verified supplement, then there's no testing that goes on, and so you have no idea, about what, if any, contaminants there are in there. So at the very least, looking for the USP verified label can be helpful in trying to mitigate some of that risk.
This is an excellent conversation that providers should consider talking with their patients about, because as we all know, and all of us may be taking some sort of supplement, and many patients are getting their information about how to feel better through Reels, TikTok, Facebook, Instagram, and those things are quickly shared and seem so perfect when we're not feeling well. So having that description is really helpful to understand not only what, but how in the heck does it get in there. So thank you.
Yeah, and though we use these combination herbal supplements as kind of the prototype, since that's where it's first really discovered and described, this really applies to any herbal supplement product that's on the market. So even just a single root, and I'm not going to name ones by name, but any of the even single agent herbal products, if it's grown from a plant or root, and it's sold as a supplement, there needs to be some caution and at least look for that label.
Mm-hmm. Great. So continue to answer questions. Again, feel free to unmute yourself, ask the question, or chat it in. And while you're thinking of those questions, I'm going to get ready for our next area that we're going to be talking about. So again, keep chatting in those questions, and we will pause to answer those. But while we wait for the questions to come in, let's just talk a little bit about Superior Health Connect It is our learning environment for Superior Health participants, which you are all part of by attending this session and the other sessions and future sessions. A lot of information out there in a nice kind of one-stop shop place. We have created a collaborative area for this particular group, all of you who are attending this session. And in the materials I sent you, you will see on this particular slide, you'll be able to click on the link, Champion the Cause of CKD, and that will allow you to very quickly join the group. While I switch over to that area again, please continue to send in some questions, because it's great to have Dr. Siegel here, and that's, you know, this is our time. This is our opportunity to get to talk with him. And do know that if you have further questions after today, we certainly can have him answer those questions. He is available to us. You can always send us an email or even go in through the group area. I'm going to share.
Siegel, this is Debbie Bow from Midwest Kidney Network. Just a question. You had talked about the gene for the Black patients. Does that have to be one from one parent, one from the other in order for that to be, could you mention the double gene? How does that work?
Yeah, so typically it follows that pattern in terms of, so having one copy of the gene is not enough to put people at higher risk. You have to have two, which in this case for transmission means that you're getting one copy from each parent. So, and it's not, although there is now clinical testing for APOL1 gene, so you can send someone, you can clinically order and find out whether they're carrying both alleles for the APOL1 gene. And so sometimes that's been helpful in understanding, you know, if somebody is having very rapid progression of their kidney disease, or particularly in instances where there's, you know, there's a really strong family history of kidney disease amongst many family members, then sometimes doing that genetic testing can be helpful for both for prognostic reasons for patients, and then also for thinking about family planning and things like that can be helpful. So we're starting to see that more. Initially, this was all just in the research arena, but we are starting to use it in the clinical front as well.
And do you know if that has any implication with transplant?
That's a great question. I don't know. I have not seen that used in the determination for transplant candidacy. So in part because very, very few people are having that APOL1 gene testing actually done. So seems like it would be incredibly unfair if you had genetic testing done and all of a sudden that was potentially used against you. So I'm to the best of my knowledge, I'm going to answer that that does not seem like one of the things that would factor in. You know, obviously the primary cause of kidney disease can be important in determining transplant candidacy as it relates to the risk of recurrence, but I don't think that's one of them.
Okay, thanks.
Thanks for the questions. Those are good, Deb. I just wanted to quickly mention to all of you, as I said, if you could join our Champion the Cause of CKD group. This is something that you'll be able to regulate any notifications you may get, so it is not intrusive to your time or to your email box in case that's a concern. In this particular area, we have a place where you can engage with each other, ask questions, whether it be of our subject matter experts, and we'll get those questions to them, or of each other. Also in this area, we have the various sessions as we have moved throughout time together, and each session will be updated as we get through a session. Each session has a video link, and when it's ready, session 1 and 2 both have video links of those 2 sessions, so please feel free to share that with your colleagues. We also have in session 3, which is today, I want to point out to you that we have added something called the 5 Whys tool. And as we have hit kind of the midway point of our collaborative, we do have a couple more sessions coming up. We do want you to pause and think about the things that you have learned so far, and think about in your process within your clinic, or perhaps it's within your organization. I know we have a couple of folks here who are not clinicians and they are running public health programs. Think about the areas that you've learned about and what area may be something interesting you should look into, and find out what sort of goals from your learning that you should have, and kind of dive in and find out if you're not quite at that goal. This 5 Whys tool is something that you can share with your team. If you'd like any sort of assistance with that, you certainly can reach back to me. I'm very happy to work with you and your team if you wanted to develop sort of the root cause analysis about why you're not at a particular goal. And again, we really hope that you will go out and join us on Connect and take a look at our group area. I also am posting here the event evaluation, very helpful to us. Not too many folks have really suggested anything else that we should be talking with you about during this collaborative. So please take time to let us know if there's something more that we're missing or you want us to go back to in the evaluation, or you can engage with us through email or Connect. Coming up next session 4, we're going to talk a bit about nutrition, and then we're going to talk about the additional community supports and social determinants of health, and just kind of talking around that area. We're also going to be talking about cultural humility and a number of other kind of subjects. We're going to kind of pack all that in session 4, but we'll also give you some materials to look at on your own ahead of time. Let's just have me pause now again and see what other questions that you have for Dr. Siegel. And again, chat them in, or you can open up your mic and ask the question. Hopefully you're receiving the session materials ahead of time. And remember the intent. We really hope that not only are you taking in this information, but you're turning around and sharing it with everyone on your team. If we're speaking about a clinic, as you know, you have nurses that come in and talk with your patients prior to you arriving. You have reception. You have folks who are medical assistants. Everyone has a part of the visit of the patient. Finding bits and pieces of this information that feels like it fits with each of those folks, very important to pass it along, and also think about your processes as a full team. All right. Well, I am not seeing any other questions in the chat. I'm going to leave the window open so people can click on the evaluation. Any parting comments from you, Dr. Siegel?
Nope, I hope this was helpful and I appreciate the opportunity. So thanks so much.
Oh, the thanks goes to you. You've really brought a lot of information for us to think about, and I'm sure we'll be in touch with some additional questions in the future. So thank you, everyone, and have a good rest of your day. I hope the sun is shining as it is for me here today.